get us. Okay, so you all heard we are starting our recording. I'm really thrilled today to welcome you to our webinar, Promoting Lifestyle Change to Improve Population Health, using VA's MOVE Weight Management Program for Veterans. You can see today we have two boxes on the bottom. One is the chat function, which is for any comments you might have, but if you have a question for our presenter today, I'm going to ask you to use the Q&A box on your toolbar at the bottom. I will be monitoring both of those during the webinar today, and hopefully Dr. Raffa will have some time at the end to answer any questions that you might have as they come up. So let's get started. Let me introduce our amazing speaker today. Dr. Susan Raffa is the National Program Director for Weight Management for the Veterans Health Administration. In this role, she provides clinical and administrative guidance for VA's MOVE Weight Management Program for Veterans, as well as other weight management initiatives and research collaborations. In addition to being a Division 18 VA section member, she also serves as co-chair for the Committee on Science and Practice for APA's Division 12. So on that note, Dr. Raffa, take it away. We're really looking forward to your presentation.
Great, thank you so much for having me, and we will get started. Just one question, can you see my mouse move at all? I'm just wondering if I can point things out.
I am not seeing it. I think you might have to activate oh, there it is. Yep.
Okay.
Seeing it now.
Great. Thanks. Okay, so we'll get started. And here are the objectives for today. So I will start by describing the challenge of obesity and the link between overweight and obesity and health risks. Then we'll identify evidence-based interventions for weight management, including comprehensive lifestyle intervention, pharmacotherapy, and bariatric procedures. I'll describe opportunities for psychologists to enhance weight management programming and support patients in self-management of overweight and obesity. And finally, I'll describe the relationship between mental health conditions and obesity. So to get started, we'll talk about the challenge of obesity and associated health risks. Here, this slide shows obesity trends in US adults from 1998 through 2018, and this is in adults 20 and older, where obesity is defined as body mass index of 30 or greater, and severe obesity is defined as body mass index of 40 or greater. And here we see a significant increasing linear trend from 1999 to 2018. So you can see in 1999, there were 30.5% of US adults with obesity, and that's up to 42.4% in 2018. And similarly, severe obesity increased from 4.7, there comes my pointer, 4.7% in 1999 up to 9.2% in 2018. And this is prevalence of obesity, overweight and obesity in veterans who receive care in the Veterans Health Administration. So here again, similar to what we just saw, we see increasing rates of obesity. So that's the red line. That's again a BMI greater than or equal to 30. So in 2000, we were below 35%. And in fiscal year 2021, we were at 45% of veterans receiving care in VHA having obesity. And here are data about the prevalence of obesity by race and ethnicity. So this is state level data, and it shows the percentage of adults in each state with a BMI that of 30 or greater. So again, the darker colors show greater percentages of adults with obesity. So you can see in the slide in the middle right here, there are 7, for non-Hispanic whites, there are 7 states where there are with an obesity prevalence of 35% or higher. So that's the threshold for red. For non-Hispanic Blacks in the bottom left corner, there are 35 states where the prevalence of obesity was 35% or higher. And in sorry, I'm not going to try pointing anymore because I'm trying to use two different screens here. So yes, I said there were 35 states where non-Hispanic Blacks had 35% obesity. And then you can see also the number of states in red where Hispanic adults have a rate of obesity of 35% or more. So we see disparities here in the rates of obesity by race and ethnicity. And now looking at data in VA stratified by gender, here we're looking at rates of obesity by race and ethnicity among women primary care patients in VHA. So the darker blue lines show rates that are significantly different from the overall population rate. So the overall population obesity mean is 41%, and the darker bars represent a difference that's 5% or greater. So we can see in women veterans receiving VHA care, obesity is present in greater rates in Black or African American females and Native Hawaiian or other Pacific Islander females. And looking at males receiving care in VHA, again, we see that rates of obesity are higher in American Indian or Alaska Native veterans receiving care. And the reason why these rates of obesity are problematic is because there are conditions that are commonly associated with overweight and obesity. So these are commonly associated that people often think about or talk about when we talk about obesity-associated conditions. So hypertension, type 2 diabetes and prediabetes, dyslipidemia, metabolic syndrome, obstructive sleep apnea, osteoarthritis and degenerative joint disease, non-alcoholic fatty liver disease, gastroesophageal reflux disease, and some cancers. And when we look at prevalence of chronic conditions in individuals with obesity, we see, of course, that there's a higher prevalence. So this slide shows in US adults, higher prevalence of high blood pressure, high cholesterol, heart disease, and type 1 and type 2 diabetes in individuals with obesity. So that's the purple bar. So here are the higher rates. High blood pressure, 49% versus 20% in normal weight individuals. And we see similar patterns when we look at veterans receiving care in VHA. So again, in this slide, the blue bar represents obesity, a BMI class of obesity. The green bar represents overweight, and the orange bar represents normal weight or BMI lower than 25. And again, we see elevated rates of diabetes, hyperlipidemia, hypertension, ischemic heart disease is about the same regardless of obesity class, but then also in obstructive sleep apnea. And so we see these elevated rates both in veterans with obesity and with overweight. And again, this is similar to what we saw in the previous slide, but the rates are even higher. So that means that veterans are at even greater risk for morbidity and mortality, but it also means that our interventions for weight management are even more important. We have more veterans that we need to impact, more health conditions to impact. And this slide shows higher total medical expenditures by weight class and year. So here we see that in the US, obesity is associated with higher healthcare expenditures, outpacing individuals with normal weight by nearly $100 billion annually. So that's the difference between the purple line and the blue line here on this slide. And in this slide, we see data from the Global Burden of Diseases study that confirms the strong relationship between health behaviors and mortality. So among risk factors, dietary risks and high BMI were two of the top 4 leading causes of death, and low physical activity was in the top 10 in terms of leading causes of death. So you can see the risks are on the left and the bars are on the right, number of deaths. And of course, with the pandemic that we've all been experiencing, we've heard a lot about the relationship between obesity and risk for COVID-19. And we know that obesity increases the risk of severe illness from COVID-19. This slide shows potential mechanisms by which obesity may influence adverse outcomes from COVID-19. And during the pandemic, it's become even more clear that providing effective support to individuals affected by overweight and obesity is of utmost importance. There's a non-linear relationship between greater BMI and greater risk for severe COVID-19 symptoms. And overweight and obesity are also risk factors of invasive mechanical ventilation, and obesity is a risk factor for hospitalization and death. So now that I've talked about some of the darker side of this, I have some good news to share, and that is we know that modest weight loss has benefits. So as much as we know overweight and obesity have a tremendous impact on mortality and health, we know that modest weight loss has benefits. So importantly, and this is what most of my talk centers around, is the fact that lifestyle changes that produce sustained weight loss of 3 to 5% produce clinically meaningful health benefits, including reductions in triglycerides, blood glucose, HbA1c, and the risk for developing type 2 diabetes. And greater amounts of weight loss have greater health benefits, including reductions in blood pressure, reduced need for medications to control blood pressure, blood glucose and lipids, and improvements in cholesterol. And again, I want to emphasize the point here that modest weight loss here, we're talking about clinically meaningful weight loss, and that's a weight loss of 3 to 5% of baseline body weight. So we're not talking about getting people back to normal BMI or a normal weight. We're just looking at weight loss that can, at levels that can impact health. So that's the good news, is that we know that we can impact health with small, modest amounts of weight loss. And the even better news is that we have effective interventions to help individuals better manage their weight, greatly reduce their risk for chronic conditions, and improve their health and quality of life. So now I'm going to transition to talking about evidence-based interventions that are part of our population approach to management of overweight and obesity in VA. In VA, our weight management policy and programming are informed by the VA DoD clinical practice guideline for management of overweight and obesity. And I'm sure you all are familiar with clinical practice guidelines, but just to review, clinical practice guidelines are evidence-based. They provide decision support, they standardize care, they offer recommendations, they contain algorithms for care, and they include support tools. And although what I'm going to be talking about today is the VA DoD clinical practice guideline, it is consistent with and aligns with the USPSTF, so the US Preventive Services Task Force recommendations, and the 2013 American Heart Association and American College of Cardiology and Obesity Society guideline for management of overweight and obesity. So essentially what we have in VA for our guideline is consistent with other guidelines as well. So we recently updated our VA DoD clinical practice guideline, and the update was published in 2020. It included 18 evidence-based recommendations, 15 for long-term management of overweight and obesity, and 3 for short-term weight loss. And today I'm going to be focusing on the long-term management of overweight and obesity. So the recommendations associated with the interventions on the left. And before I go into some of the specific recommendations, I just wanted to review some of the key elements of weight management that are put forth by the VA/DoD clinical practice guidelines. So the emphasis is on the fact that obesity is a chronic disease that requires lifelong commitment to treatment and long-term maintenance. Shared decision-making is fundamental. Reviewing medications and eliminating obesogenic agents is really important to treat individuals with overweight and obesity. Comprehensive lifestyle intervention is central to weight management, and I'll be talking more about that in a minute. Negative energy balance should be achieved through decreasing caloric intake and increasing physical activity. Dietary supplements don't contribute to clinically meaningful weight loss or management. Pharmacotherapy and bariatric procedures may be considered in conjunction with comprehensive lifestyle intervention, and they do require long-term follow-up. There are several FDA-approved medications for weight loss, and we'll talk more about that in a few minutes. Bariatric procedures are effective for weight loss, including for type 2 diabetes and improvement in that condition, and a multifaceted approach that combines the different options, the different interventions can enhance weight loss and maintenance for individuals. So first, I'm going to talk about comprehensive lifestyle intervention, which is the foundation for other weight management interventions. So the recommendation from our clinical practice guideline is to offer an in-person group or individual comprehensive lifestyle intervention. And the definition of a comprehensive lifestyle intervention is one that includes behavioral, dietary, and physical activity components. And this should be offered to individuals with overweight or obesity. Comprehensive lifestyle intervention can be delivered to individuals or to groups of individuals in person, by phone, or through synchronous video. So that's our evidence-based recommendation. There was insufficient evidence to recommend a specific number of sessions, so there wasn't a threshold effect that we could see per se. But in general, the studies that contributed to this recommendation offered at least 12 intervention sessions in the first 12 months. And again, the goal here is sustained clinically meaningful weight loss. And that's weight loss of about 5%. A little bit later on, I'm going to talk more about the behavioral component of comprehensive lifestyle intervention. So I just mentioned that a comprehensive lifestyle intervention is one that contains behavioral, dietary, and physical activity components. We'll come back to the behavioral, but in terms of the dietary and physical activity components, physical activity can be aerobic, resistance, or lifestyle physical activity, meaning incorporating activity into your daily activities. The recommendations are for 150 minutes of moderate or vigorous physical activity per week. 300 or more minutes can be helpful for maintaining weight loss. As far as the dietary component of a comprehensive lifestyle intervention, really any evidence-based dietary approach can be used. It's more important to match to a patient's preference and what they can maintain than it is to choose any particular diet. And it's also based on medical conditions. And the key to these components is establishing a negative energy balance. So taking in fewer calories than you're expending. And there's strong evidence for comprehensive lifestyle intervention that's based on a 2018 systematic review. The review included 80 good or fair quality randomized controlled trials for weight loss, and results from 67 of the trials, which included more than 22,000 people, indicated greater weight loss from comprehensive lifestyle interventions versus minimal interventions at 12 to 18 months. So the mean difference in weight change was 2.3 kilograms, and intervention participants had 1.94 greater probability of achieving 5% weight loss. So again, those are modest numbers, but when we think about it from a population perspective, if we're able to help our population of veterans with overweight and obesity, or whatever populations we're thinking of with obesity, we are improving the health of a great number of individuals. So I wanted here, while we're talking about comprehensive lifestyle intervention, to talk a little bit about the MOVE Weight Management Program for veterans. This is VA's evidence-based population-focused approach to overweight and obesity, and it includes an offering of a comprehensive lifestyle intervention. MOVE assists veterans to achieve clinically meaningful weight loss. It's guided by national policy, and our policy is aligned with the VA/DoD clinical practice guideline. Our MOVE programs are led by MOVE coordinators and provider champions who coordinate the efforts to implement programming. Our MOVE programs are also supported by health behavior coordinators who are typically psychologists who are helping to implement the behavioral component of our comprehensive lifestyle intervention. Our MOVE program provides standardized content and materials that we establish at a national level with input from interdisciplinary professionals, including psychologists, dietitians, physical activity experts. And we use performance measurement to evaluate how we're doing with program implementation and effectiveness. This slide shows MOVE program reach. So the program was implemented nationally actually in 2006. And the blue bars show the number of new participants, so first time ever veteran participants in MOVE each year. And the figure in the foreground, the red shaded area, shows the cumulative number of participants over time. And so you can see we're getting close to 1 million unique veterans. We're in the 900,000s, I think 950,000. We've seen close to 1 million unique veterans in MOVE since 2006. And you can see in 2020 and 2021, participation rates dipped related to our shifts in care with the pandemic and limitations in providing care. But we hope to get those numbers back up again, and we're working on it. So we should be getting those numbers up soon over time. And these are MOVE outcomes. So this is outcomes in participants who are new to MOVE. So people's weight outcomes are counted once. And the left set of bars shows all participants in MOVE. So regardless of the number of visits they had, these are their outcomes. This is showing the number of individuals, again, on the left side of the left shaded bars. This is the number of individuals with any participation in MOVE who experienced clinically meaningful weight loss. So you can see in the left side, in the left shaded bars, over time, we've been increasing the number of individuals who have achieved clinically meaningful weight loss. And then if you look in the right shaded bars, the right group of shaded bars, this is individuals who received a recommended dose of MOVE. So individuals who had 12 visits in 12 months, at least 12 visits in 12 months. And so you can see that for individuals who are participating in MOVE at recommended levels, they're achieving even more of them are achieving clinically meaningful weight loss. So we're up to more than 35% achieving clinically meaningful weight loss. So this is why we want to offer veterans the opportunity to participate in a comprehensive lifestyle intervention. I wanted to say a little bit about pharmacotherapy for weight management, which is another evidence-based recommendation. So the CPG recommends that weight management medications for long-term weight loss or chronic weight management should be offered to individuals with BMI greater than or equal to 30. So that's in the obesity range. And to those with a BMI greater than or equal to 27 who also have an obesity-associated condition. So that's back to the conditions that we talked about at the beginning. The recommendation of the clinical practice guideline and what we implement in VA is that weight management medication should be used and prescribed in conjunction with comprehensive lifestyle intervention. All of the studies that evaluated weight management medications did so in conjunction with comprehensive lifestyle intervention. And of course, that behavioral behaviorally focused intervention provides support for the lifestyle changes needed for weight loss and weight management. Weight management medications can be initiated at any time during participation in a comprehensive lifestyle intervention. And this is a key point because in the past, it was required that individuals had a failed attempt at behavioral weight management, but now weight management medications can be initiated at any time. And individual choice of medication should be patient-specific, taking into account their comorbidities, the dosing of the medication, how it's administered, and the potential for side effects. And this is just a quick slide. These are the current FDA-approved medications. And the first column shows the mean weight loss versus placebo. The second column or the third column shows the percent of individuals achieving greater than or equal to 5% weight loss. And the last column shows discontinuation due to an adverse events. Now you'll see the percent achieving greater than or equal to 5% weight loss. Those levels are a lot higher than what we just saw in MOVE, where we saw about 35% achieving clinically meaningful weight loss. And again, the comparisons are very different because these are for controlled clinical trials. And of course, it's a different intervention. Depending on how the medications are used in clinical settings, in real world settings, we might expect to see lower numbers, though they would probably still be greater than what we saw for our behavioral weight management intervention. I wanted to include this slide because I think it's important. We all get a lot of questions from patients or hear from patients about using supplements and nutraceuticals. Our clinical practice guideline work group reviewed the evidence, and based on that evidence review, suggested against using dietary supplements or nutraceuticals for clinically meaningful weight loss, whether short-term or long-term. A nutraceutical is a food or dietary supplement that's believed to provide health benefits. None of these, the nutraceuticals and supplements weren't studied in conjunction with comprehensive lifestyle intervention, and the studies were low quality with limitations and confounders. So this is important for providers to know when working with patients who may bring up questions about using supplements and nutraceuticals. And the last evidence-based intervention that I wanted to mention is metabolic or bariatric surgery. So the CPG recommends that we offer the option of metabolic or bariatric surgery in conjunction with comprehensive lifestyle to patients with BMI greater than or equal to 30 and type 2 diabetes, individuals with a BMI greater than or equal to 35 and an obesity-related comorbidity, and to individuals with BMI greater than or equal to 40. And again, this is based on the evidence review. So that's how we came up with different recommendations for different levels of obesity and comorbidities. And a secondary recommendation is to offer intragastric balloons in conjunction with comprehensive lifestyle intervention to patients with obesity who prioritize short-term weight loss. That's weight loss of about 6 months. And just a few words about the types of procedures, or a figure to show you the different types of procedures. So this is a picture of the different types of procedures ranging from a lowest level of invasiveness and complications in the left corner to the right corner, but also the relative weight loss. So the red line traces the relative weight loss. And these are weight outcomes associated with metabolic or bariatric surgery. So the columns show the different types of procedure that were described on the prior slide. The mean weight loss and percentage, so 20 to 30%, 25 to 35%, and 30 to 40%. the pattern of weight loss, and the chance for weight regain or need for revision. So again, the weight outcomes are really positive here. And obesity is, metabolic or bariatric surgery are the most durable, weight management intervention. And studies have shown that it can reduce obesity-associated conditions. So in type 2 diabetes, we see 60 to 85% remission. For hypertension, we see up to 40% remission. Cardiovascular events are reduced by 50 to 67%. Non-alcoholic fatty liver disease has 37% resolution of inflammation. Obstructive sleep apnea is resolved 45 to 75%, and polycystic ovary syndrome up to 90% resolved with surgery. And long-term mortality is reduced by 25 to 50% and 42% in veterans. So studies have also shown marked improvements in other conditions, including dyslipidemia, asthma, stress incontinence, chronic pain. So there are lots of significant clinically meaningful outcomes associated with bariatric or metabolic surgery. I did want to mention that bariatric or metabolic surgery are also associated with complications, or they have complications that are associated with them. So they aren't without risk. And this is just a list of potential complications by surgery type, again, based on the surgeries that were listed on the prior figure. For surgical mortality overall at 30 days, the rates are between 0.3% and up to 2%. So of course, that's more significant than the risks associated with participation in behavioral weight management, which are pretty minimal. So now that I've gone over the evidence-based interventions, I wanted to talk about opportunities for psychologists to address overweight and obesity, both in terms of clinical practice, but also in terms of thinking about participating in programming or supporting programming that might be available at a facility. So this algorithm depicts our population approach to overweight and obesity. So it starts at the top with screening, looking at individuals enrolled in the healthcare system and screening for overweight and obesity. The right-hand set of arrows, so the arrows going down the right-hand side, if the patient does screen positive for overweight or obesity, walks through a process of shared decision-making to choose among weight management options, emphasizing the central role of comprehensive lifestyle intervention and assessing progress towards treatment goals. So it's a feedback loop of assessing readiness for treatment, engaging individuals in treatment, assessing progress in treatment, and supporting maintenance or supporting continued treatment if goals haven't been met. The boxes on the left-hand side show our population approach. So even for individuals who are not in the overweight or obesity category, or for individuals who aren't ready to engage in treatment, we still want to offer guidance about healthy eating and physical activity and potential counseling. And we do want to continue to readdress, especially for those who could benefit from a comprehensive lifestyle intervention. We want to readdress and reassess at subsequent visits. The role of psychologists is also important for promoting engagement. So this was on the previous slide in terms of engaging veterans in and individuals in shared decision-making. This is a tool that we have for MOVE for promoting engagement in weight management. So this process includes asking permission to discuss weight management, exploring readiness and experience with weight management in the past, supporting and affirming any interest, and past benefits and current and past successes, and also challenges, sharing information with permission and confirming next steps. Psychologists can also participate by supporting the behavioral strategies of comprehensive lifestyle intervention. So I mentioned earlier that there are 3 components to a comprehensive lifestyle intervention. And for the behavioral component, there are several evidence-based strategies. The core behavior change strategies, which are based on social cognitive theory, include SMART goal setting, self-monitoring, and iterative problem solving and skill building. So here we see that a relationship-based approach facilitates the process of assessment, information sharing, shared decision-making, collaborative goal setting, and problem solving. So the assessment should be of needs, values, preferences, and motivation. Information sharing should include asking permission and eliciting what veterans or patients already know about weight management. Shared decision-making includes tools of evocation, agenda mapping, and autonomy support. Collaborative goal setting involves finding common ground between provider and participant aspirations. And problem solving involves addressing barriers, particularly those that arise during treatment. And of course, problem solving is related to skill building and increasing self-efficacy and confidence to address barriers and to engage in the intervention. And all of these are part of the process of self-management support that providers provide to veterans or patients. So self-management is what the participant or patient or veteran does, and support is what the psychologist or other provider does. And psychologists can be involved, like I said, by supporting self-management. So these are just a few tools that we have to provide self-management support. We have a workbook that we developed and a facilitator guide. So those really are the foundation for our comprehensive lifestyle intervention. But we also have tools that can be used on their own for veterans to engage in self-management without clinical intervention. And that includes a mobile app. We have videos that are available on our website. And this clinician guide that I have pasted here shows all the different technology options that we have, different tools that veterans can use either on their own or in combination with clinical care to support their weight management efforts. And of course, psychologists can be involved by participating on an interdisciplinary weight management team. This figure shows members of an interdisciplinary weight management team, or our MOVE team in VA. So it includes, in VA, we have a MOVE coordinator and provider champion, dietitians, rehab specialists, exercise physiologists, health psychologists, primary care. Our healthy living team includes members of our health promotion and disease prevention teams that are located at facilities. So the health psychologist or psychologist has an important role on the interdisciplinary team in supporting behavior change, and also when bariatric surgery is an option that's pursued. Psychologists also have a role in recognizing the complexity of obesity. And so this figure is a little bit overwhelming, and I didn't include it for us to tackle, but I did want to include it to just show the complex system that contributes to the development of obesity over time. So here, the Foresight report mapped out more than 100 variables that can contribute to the energy balance, the positive energy balance that contributes to overweight and obesity. So a lot of times obesity or weight management treatment can be simplified into, oh, you just need to do X, Y, or Z, and a lot of individual responsibility is placed on a person. And this really is trying to communicate that there are so many factors. Yes, there are things that can be changed on an individual level, but there are also so many factors that are out of an individual's control that are influencing the development of obesity in individuals. This is kind of a simplified version, or it's collapsing or grouping the 100 variables that were on the previous slide into 7 cross-cutting themes. So biology, activity, environment, physical activity, societal influences, individual psychology, food environment, and food consumption. So those are all factors exerting on or influencing the development of obesity. And again, psychologists have a really important role in helping not only the individuals they're working with to understand the complexity of obesity, but also others as well. And that relates to the next area where psychologists can have an impact, and that's understanding weight bias. So weight bias refers to negative attitudes, beliefs, judgments, and stereotypes towards individuals because of their weight. We know that it often leads to prejudice and discrimination. And in the US, the prevalence of weight discrimination is comparable to racial discrimination. It occurs across a wide range of settings, including our healthcare setting. And it can be explicit or implicit. It fosters blame and intolerance that impacts quality of life for people with obesity. It's dehumanizing and damaging and results in obesity stigma. And it has negative health consequences for individuals who experience it. So psychological, emotional, health-related consequences as well, which also can serve to reinforce weight gain and obesity. So not only do psychologists have a role in understanding weight bias, but also in addressing weight bias. So some concrete things that we're working on implementing in our program, but we also need everyone to work on, is recognizing, first and foremost, recognizing that obesity stigma exists in all aspects of life, increasing education and awareness about the damaging and lasting effects of weight bias, making efforts to recognize it all across the settings that I mentioned on the previous slide, including in social media and in our healthcare system. For all of us as individuals, identifying our own potential biases and responding to biases. So using person first language, or so in general in our programming, we're using person first language, but of course the best thing always is to ask a person how they would like to be referred. So you'll notice in this presentation, I've been talking about people with obesity and people with overweight. I haven't been talking about obese persons. So that's just an example. And we want to respectfully portray individuals with obesity in images and language. And so, I would challenge all of you to start paying attention to ways that people with obesity are displayed, whether it's in healthcare materials, in the news, on TV shows, in social media. Once you start paying attention, it's hard to unsee all of these negative ways that individuals are being portrayed. And back to the 100 variable slide that I shared a few minutes ago, remembering that obesity is a complex disease, and helping people to understand that as well. And I see that we're at 3:45, so I have just a few more slides. Another way that psychologists can support addressing overweight and obesity is by providing feedback. These are results from a survey that we did with veterans who participated in our MOVE weight management program. And this asked them about if they received feedback from a clinician about their physical activity diary and their food diary. And you can see in the the blue represents people who said, yes, I did receive feedback, and the green represents people who said, no, I didn't receive feedback. And the customer satisfaction index, so the level of satisfaction with the program, was different based on whether somebody received feedback on their physical activity diary and food diary. So for physical activity, the customer satisfaction score was 90 for people who did receive feedback on their physical activity diary, and it was 78 for those who didn't. Same thing for food diary. And so important to remember that not only are these tools really, the self-monitoring tools really helpful in an intervention in themselves, they're also important to incorporate into treatment and to provide feedback. And another way that psychologists can be supportive of addressing overweight and obesity is through coaching. So this is that same survey that we did with MOVE participants, and 45% identified that the most important thing that kept them involved in the program was coaching received from a healthcare professional. And when we think about coaching, we think both about coaching of patients, but also coaching other clinicians as well. In VA, we have a clinician coaching program where psychologists and other behavioral health providers do provide clinician coaching to other types of providers who might be implementing or delivering MOVE or weight management intervention. And the last way that I wanted to mention that psychologists could help address overweight and obesity is by considering the effects of medications. So this is an infographic that we developed as part of the clinical practice guideline. And it includes medications that have the potential for weight gain and medications that are more weight neutral or have the potential for weight loss. And they're categorized by type of medication. And so the more that we have all types of clinicians and patients paying attention to these things, the more action we can take. So, you know, especially in VA, we know that lots of our veterans are on lots of medications, and it's important to stop and take a look and see if there are any that can be adjusted or changed in our patients who have overweight and obesity. And just a few slides about mental health and obesity, and then I will wrap up. This slide looks at the prevalence of obesity among veterans with mental health conditions. So again, similar to the slide that we looked at the beginning here, we have bolded places where the difference is more than 5% from the population level. So we see that rates of obesity are higher in individuals, both men and women, with major depressive disorder, bipolar disorder, post-traumatic stress disorder, and in women with schizophrenia. And like we saw on the previous slide, the epidemiological literature shows that veterans with PTSD have disproportionately high rates of obesity, as well as associated illnesses like cardiovascular disease. Our office recently supported a study where a team of researchers found that, unfortunately, our MOVE intervention is less effective at producing clinically meaningful weight loss for veterans with PTSD, despite comparable utilization of the intervention. This is likely due in part to the fact that veterans with PTSD have unique barriers to activity and healthy eating. For example, hyperarousal symptoms can interfere with exercising for veterans with PTSD. PTSD and depression are also associated with binge eating, emotional eating, and night eating. And depression is associated with poor health behaviors with or without PTSD. We know that sleep is often poor among people who have mental health conditions, and sleep disorders are associated with poor eating and excess weight as well. The good news is there is a growing body of research that shows that weight management has the potential to improve symptoms of mental health conditions. And we do have researchers in VA working on looking at that and ways that we can enhance our MOVE intervention to enhance outcomes for individuals with mental health conditions. And this is the last slide that I'll share. So knowing that adults with serious mental illness are at increased risk for obesity and obesity-associated conditions and premature mortality, knowing that it becomes important to understand factors that might relate to the disproportionate disease burden. So this is a comprehensive model that's been put forth by Herster and Young, looking at the unique factors that may influence overweight and obesity in individuals with serious mental illness. So the causes of disproportionate obesity include psychiatric symptoms, physiological factors, contextual factors, psychology, and knowledge and beliefs, psychiatric medications, physiology, and all of those can exert an influence on body mass index, either independently or through physical activity and healthy diet. So understanding those factors helps us to address the disproportionate rates of obesity with the following. So we see the suggestions at the bottom of the slide, including screening and referral and mental health, outreaching to address barriers, unique barriers, programs that address unique barriers to physical activity and healthy diet, changing medications, and addressing contextual barriers. So a lot of those we've talked about in our population approach to overweight and obesity, and then this is specifically looking at addressing them in the population of individuals with serious mental illness and obesity. So we are definitely working on an MBA, and we have a ways to go on that as well. So to sum up, overweight and obesity are common in US adults and veterans receiving VA care. They are associated with morbidity, mortality, and they disproportionately affect subpopulations. Our population approach to obesity includes screening and counseling, as well as referral to evidence-based interventions. Importantly, our evidence-based interventions target clinically meaningful weight loss. We're not looking for weight getting back to what one might consider normal, whatever that means. It's clinically meaningful. Psychologists have an important role in addressing obesity, and we talked about the different ways that psychologists can support efforts both on a programmatic and healthcare system level and with individual patients. And obesity is common in individuals with mental health conditions, and they can serve as additional barriers to effective treatment. That is all for today. Thank you everybody so much for listening.
That was so super fabulous, Sue. Just chock full of not just information, but resources. Want to invite, there are no questions that I can see in the Q&A box. So if people have questions, you can go ahead and put them there as you're thinking about that. And I know folks are going to start dropping off for their next appointment, but Dr. Franklin did have a comment in the chat that is, interesting, right? That labs tend to be ordered for people who are overweight versus folks who might be smaller. So you might have, in terms of comparison, right? You're not going to have perhaps as many, let's say, a normally distributed group of folks who are not overweight having those same labs requested. So I don't know if you wanted to say something about that, or if there are other, ways to look at the differences in metabolic issues or, other issues between people who are overweight versus not.
Yeah, so I think this kind of gets at the whole gist of a population approach. So we're making recommendations for what's good in general for the population. That doesn't take the place of individual clinical decision making. In terms of recommendations for labs or not labs for individuals who might not have overweight and obesity. I can't really speak to that, but the one thing I will say is this comes up around screening for diabetes, and people often say, you know, should we be screening for diabetes, and should we be treating veterans differently if they have pre-diabetes? And or actually, the question is, should we screen for pre-diabetes? And we don't have a recommendation about that, because the intervention is the same. Our intervention is adapted from the diabetes prevention program. It's not, but it's not specific to prevention of diabetes. It's about preventing and reducing risk for all different kinds of obesity-related conditions. So screening for prediabetes doesn't change the intervention of referral to comprehensive lifestyle intervention.
Yeah, that makes a lot of sense. You're getting lots of thank yous, and that was an excellent presentation in the chat, so I'll save that for you. But I really loved how you paid attention in your presentation to the role of psychologists. I think so many times, right, we really focus on the mental health aspects and symptomatology, and don't think about the other issues that might potentially be helpful to focus on in treatment. So I just thought you did a fantastic job of talking about that and how it can be approached in treatment. So we really thank you all for attending today. Thank you to Dr. Raffa for her excellent presentation, her ongoing work in VA to help veterans lose weight or manage weight and improve their health. Unfortunately, I do not have the link today to the SurveyMonkey CEU survey, but we will be sending that out to everybody who was registered in the next day or so. I put that information in the chat, so rest assured, if you were in the webinar, you obviously registered, and you will get the link from SurveyMonkey in the next day or two. And then also this recording and Dr. Raffa's slides will be available, as I indicated, on the Division 18 VA section webinar page, probably in about 2 or 3 days. It varies depending on how long it takes APA to upload them. So we really do appreciate everyone's time. Thanks again, Dr. Raffa, for this just amazing presentation, so full of excellent information and resources. And we look forward to seeing you all again next month. Thanks, everybody. Take care.
Thanks everybody. Bye.